The setting of acquired resistance for EGFR mutation positive non-small cell lung cancer has had a lot of change in a very short time. If you had asked a year or two ago, I would have said we had two strong leading candidates with osimertinib as one, that's AZD9291, and also an agent from Clovis, CO1686, known as rosiletinib. But about late 2015, questions came up about whether the response rate quoted for rosiletinib was actually confirmed or unconfirmed, and it seemed that the confirmed response rate was much lower. It ended up getting into some hurdles with ODAC and the FDA saying that they weren't going to approve it without a phase 3 trial, and then very suddenly in early May, rosiletinib is withdrawn, trials closed, and that's that. At the same time, over the last 6-7 months, we've had big changes for osimertinib, where it's actually approved by the FDA in November of 2015 and commercially available. With that, I would say it makes it extremely valuable to test for T790M in patients who develop acquired resistance on a first or second generation EGFR TKI before that. So now we have a clear answer to the question of why would you repeat a biopsy, whether that's tissue, a liquid biopsy like plasma or urine, but whatever. There's a clear, valuable answer to that question. T790M is present in 50 to 60% of patients who have acquired resistance, and if you have that found, osimertinib, or now commercially available as Tagrisso, is associated with a response rate of about 60%, disease control in 90%, and it can be very long-lasting and usually very well tolerated. So a very compelling answer that's, I believe, should change the standard of care to make it necessary to look for and hope to find a T790M mutation.